Open fracture management. So we already know that open fracture is a fracture that is exposed to the external environment. Always write a definition of fracture first. That is, a fracture is a breach in the continuity of the cortex of the bone, and open fracture is the one where it is exposed to the external environment. So what are the problems in the open fracture? The problems in the open fracture are a high risk of infection, that is osteomyelitis. Then there is a union problem. If there is a bone loss at the time of injury, or if there is a loss of fracture hematoma, then secondary infections or missing soft tissue cover, and difficulty in using the traditional immobilization methods. The Gustilo-Anderson classification is, we know, as a type 1, that is here the wound is less than 1 centimeter, clean. Type 2, the wound is more than 1 centimeter and mild to moderate soft tissue damage is present. In type 3, there is extensive soft tissue damage and there is going to be contamination. So in type 3A, it is going to be adequate soft tissue cover is still present. In type 3B, periosteal stripping has taken place, bone exposure, and in type 3C, there is vascular injury. So these are the different types in Gustilo-Anderson classification. Now talking about the management protocol for this open compound fracture. So in the phase 1, we have to talk about the emergency care at the site. So at the accident site, you have to do a bleeding control by externally pressurizing it with a tourniquet. Then the wound care should be taken by washing it with clean water and covering it with a sterile cloth. Then splintage, that is immobilize the fractures with anything available, that is stick or anything. And then the bone fragment, if any is lying out, then you have to wash it with clean water and bring it to the hospital in clean cloth. Then in emergency department at the hospital, you have to assess the neurovascular status of the distal part. Then wound case, again the same thing, that is you have to wash under aseptic conditions and sterile dressing should be applied. The protruding bone, it should be replaced to prevent the skin devascularization. The antibiotics, generally third generation cephalosporins and aminoglycosides are given. TT prophylaxis is the must. Analgesics and splintage should be given. Now definitive care, it consists of first of wound care and then the fracture management. So we have to do the wound debridement. So in the case of wound debridement, there are certain excision policies. So in the skin, you have to excise it minimally, while the muscles and the fascia that are affected, you have to excise it literally. Then tendons, only the bad lacerated tendons should be removed. In the bones, the margins of the bones, they should be nibbled with the help of bone nibbler. And the fragments which have a soft tissue attachment, they should be replaced, while those fragments which do not have any soft tissue attachment, they should be completely discarded. Muscle viability, it can be checked by pinching the muscle with the help of forceps, and if it contracts, then that means the muscle is viable. Then wound closure decision. So if it's a clean wound, then you can close it within 6 hours. If it's a contaminated wound, then you have to debride it after 6 to 8 hours. If you are not sure about it, don't close the wound. Leave it open. Then the next is fracture management. So the fracture management, we have to use a plaster cast. The plaster cast is used in moderate wound and helps with stable reduction. Then pins and plaster are used when there is unstable reduction. Then skeletal traction should be used. Skeletal traction is generally used for big wounds and circumferential skin loss is present. Then external fixation. External fixation is generally done when there is extensive soft tissue damage, and it allows the wound access. It is done with the help of pins or ring fixators, that is Lizardo technique. Internal fixation, it is done in clean wound early presentation with the help of nails and plates. External fixator, as I said, there are pin fixators and ring fixators. And then next is rehabilitation. So in the rehabilitation, there is joint mobilization. So joint mobilization should be done as soon as possible. Muscle exercises, weight bearing exercises, and walking aids should be used.